gone.
Yes, I got it. Yes, that is a symbol of it. It's okay.
Yeah. Excellent.
So this is a team effort, as you see. Team Maitri FACEMI. You may wonder, how did we do it as a team effort? This is not any field work. Every member here in our group, many members being Bengaluru, it's a urban metropolis, and we have people here not only from Karnataka, but also from neighboring states in south. We also have from Orissa, Bihar, Bengal, even Jammu. We have a member in Bangalore, people who are migrated to Bangalore for professional work, for their jobs in connection with their work, but who are also become in the process families with loved ones under treatment for mental illness. So Team Maitri is a collective work, and I'm so grateful to Team Maitri for having contributed the narratives which are still going on. As Dr. Murthy said, stories of women are endless. That I said in 93, but Dr. Murthy is continuing even to this day. So with this, I go to the next one. How do I, yeah. Now, to begin with, this is something which all of you know, but I only thing is I put it in this thing. If you see on the left side of the screen, we have models of care for person with mental illness. What are the support sources for support? One is institutional care, which means hospital facilities, destitute homes, asylum, etc. Maybe 5% of the mentally ill population in India are in institutions still. Then we have community care, around 10%. These are daycare centers, rehab or long-term homes like MPA. This may be government, private, free or fees levied. We have both. On the one hand, we have free charity-run homes, daycare centers and homes, long-term homes, as well as very expensive residential care facilities, commercially based care facilities, nevertheless providing service. So they cater to community care facilities, almost 10% of persons with mental illness. Street care is familiar to all of you, the wandering mentally ill people who still constitute around 20%. Now these 5%, 10%, 20%, I got it from a newspaper source. And unfortunately, I'm not able to identify or track that. So, but I'm very clear on this because the transparency, the PPT I prepared was sometime long back, and so I'm sure of these facts. Now, 5, 10, and 20 makes 35%. What about the rest of 65% of mentally ill population of the people with mental illness in India? Where do they stay? They, on the right side of the screen, you see a very big family care model. According to Government of India statistics, 65% to 70% stay in families, or what I call as family care. About this almost comes to 400 to 500 millions of families with 300 to 400 million users. Now, these are little extrapolated figures because 2016 NIMHANS survey says almost 280 to 300 million people in need of treatment in India. So by now it must have been 2016. We are almost nearing a decade. So I thought it may be 400 with 500 member families taking care of them. 500 million families taking care of them. And what is the kind of care families provide? It may sound very simple to you. It may sound very commonplace, very familiar. We provide end-to-end care. We provide care for the child, for the youth, adults, elderly, whichever age spans across in the families. We provide from medicines to marriage, divorce maybe, employment to entertainment. All this for the person with mental illness, 24/7 we provide the care. Employment to entertainment, please understand. What is the one end of the spectrum is employment. We look for jobs. I get mails. We put in our groups. Is there anybody who can employ? They have become all right. The other side is entertainment. They don't have friends. Feel so lonely. What do? The family member sits. With that person, we can't see a loved one sitting alone in a corner of the house. We provide entertainment. We don't realize we are doing all this. That's what I want to show. It flows along the rhythms of life for us. And perhaps when the professionals are doing their research, please understand there is always an undercurrent of very positive and productive emotions that go along with it. The emotions are always not negative. It's a 24/7 open-ended service. Family is social security in India. Family care is an independent factor or variable by itself. It is not realistic to make it part of community care. And therefore, there is a shift from community care to family care in this presentation. The paradigm shifts completely. We are not saying there is no community care or community care is not useful. There is no judgment. It's not doing that. All that we are trying to say is it is not adequate for various reasons. And why do we say it is not adequate? Let us see. We go from numbers to narratives. What is the narrative? I told you the numbers you saw just now, 65% to 70% of persons in mental illness, like most disabled persons in India, they live in the family. Family is the biggest caregiving model. The model is a separate model of care by itself. It's not correct to club it along and merge it along with the community and hide it within community, because when there is a crisis, I don't have a community to reach. When there is a crisis, which is the community? My WhatsApp group is a community, yes, but that's a community according to the people with Facebook or whatever they call it community. Is it a community which is there where I can reach in crisis? No, not exactly. That is unfortunately the tragedy of the urban development, the urban scenario, the metropolis like in Bangalore for those with mental illness. So listen to some stories that we have, and it's currently going on. I'm just going to narrate one single story. This is a family which has come from North India. I don't want to mention the state. The widowed mother with two daughters. The elder daughter is a very senior computer, or what do you call it, software techie in one of the MNCs in Bangalore, and she has been there for a long time. The second daughter is one under treatment. This mother is living on her pension. They're from government. Her late husband was a state government servant. The second daughter refuses medication because she sincerely believes that nothing is wrong with her. Now, I'm not going to say she is ill or not ill, but I'm just stating facts. And there is a big battle for this. The sister as well as the mother who live with her. Of course, sister's family is also there with her, sister's husband. It's a typical Indian family situation. The mother had to move to Bangalore because there was nobody back home. There are no facilities back home. They didn't have a psychiatrist around 35 to 40 kilometers. Even if the person makes up her mind to have treatment, the widowed mother had to take her 30 to 40 kilometers from the place where she lived. It was a small town in North India. Anyway, so this girl refuses medication, and they have gone through serious crisis. The emergency ambulance and other things have been a big challenge for the mother as well as the elder sister. And every time, even now, even today, she refuses to take medicine. They go through a crisis. They shift her to the hospital. The hospital treats her somehow for 1 or 2 months, comes back, again back to square one. Now, what do we do? How do we advocate follow-up care? How do we tell this mother? Early intervention, they could never do. And I see in my whatever 2-decade or 3-decade exposure with so many thousands of families, on an average, it takes 3 to 4 years for a family to recognize that this is mental illness and there is treatment available for it, irrespective of their whether they are educated or not educated. That is a secondary issue. It is an irrelevant issue, in fact. The more educated are, in fact, they delay treatment more, because the more educated families also become achieving families. So they don't want anybody who is a non-achiever. So that becomes a problem. They can't accept. The denial gets prolonged and protracted, the denial phase. Anyway, coming back to the story, this is the story. How do we treat? How does one help this girl to accept that some amount of medication helps her to be stable and enjoy whatever she wants to do? She's also a highly qualified girl. I can go on and on with stories, but in FACEMI, as I said, we don't believe just in stories or numbers and percentages. We must see what. So going out of this 68% to 70% under family care, these stories make me find a reason. Why do we advocate assisted home care? Again, I'm coming back to numbers. The treatment dropouts in India, people who drop out of treatment, range from 14% to 64%, according to the article from Indian Journal of Psychiatry. 2 out of 10 visit OPDs. It's a very strange illness. We compare mental illness to diabetes, but that is, the comparison stops at this stage. A diabetic seeks treatment, goes out of the way to seek help, medical help, visits all sorts of doctors. On the contrary, it's different in the case of mental illness. Find it very difficult for anybody, if it's me or you or anybody who falls in. It takes time for us to accept the fact that there's something wrong with my brain. So only 2 out of 10 visit OPD. What about the 8? And therefore, national treatment gap is 80% to 90% in India. When this is presented in international conferences, I feel like breaking down. I feel like shedding the same tears I shed in MPA when I saw my son. Why should we have 80% to 90% treatment? We have a huge family wealth. We have brilliant psychiatrists, maybe not enough, not adequate, but brilliant. We have a committed government which has realized, especially after the COVID, that mental health is important. All the 620 districts in India are all covered with the DMHP programs. Why should there be a treatment gap of 80 to 90%? Because only 2 out of 10 visit OPD. Others, it's a big challenge for families to take them. Now, another important thing, sociological, not social determinants of mental health are changing in the country. Example, urban migration is on the rise, but not just migrant labor in unorganized sector, but also the professional middle class. This is very important, being ignored by the government, and this is one of the foremost campaigns for FACEMI. We openly tell the government we are negotiating with. Currently, we are negotiating with 3 state governments for assisted home care, and NIMHANS running the pilot program for us. Government of Karnataka has been a great piece of advertisement for us, a credibility established, and it has given us a lot of status. I'm so grateful to Government of India and NIMHANS for doing this. So the professional middle class, when people say social determinants, as a sociologist, I wake up, look, it's not social. Look at the class structure. That is sociological. Look at the stratification pattern in a city like Bangalore. It is changing. We not only have people coming as workers, but we have people middle class. Look at this girl I'm talking about, whose sister is a senior. She's not from Bengaluru. She's not from Karnataka. For every festival or their Durga Puja, they go back home. They go back home to their roots. They're also migrants, but they're also Indians. They're also in the city. The 2017 Mental Health Care Act is also for them, not only just for residents of Karnataka. And this is very important, that is being missed, the tax-paying middle class, Madhya Varg. as the Prime Minister says. 34% taxpayers are from the middle class. And almost 48% taxation is collected from the middle class, the professional middle class, the salaried middle class among them. Maharashtra population 11.3 crores, 55% live in urban and 45% in rural. And the same thing we can find for other states, including Bangalore. The NIMHANS survey 2016 shows a higher rate of mental disorders in urban than rural areas. And most important, in urban areas, whether it is rich or poor, middle class or below poverty class, the working families are also achieving families. Even PMIs, persons with mental illness, are under aspirational plans. They don't want to sit and weave baskets anymore, even though they come from the slums. We see a truck driver's son being IIT topper. Why not PMIs? Aim for that. But what is the system support families have? Whether they are BPL families or middle class families, it is so tough to begin with the fundamental, the basics of psychiatric treatment, that is early intervention and diagnosis. Does the mental health service of the government cater to these new realities of a growing middle class urban population? This is a question. Yes, it takes time, and I'm sure we are doing the needful. So as a result, you see this, there is a mismatch between services and social change, or sociological changes, if I can add. Underutilization of government services because only 2 out of 10 reach the OPD. Thirdly, the right to access mental health care, as spelled out in Section 18.1 of the Mental Health Act 2017, is not facilitated. Families are challenged by system deficits. Friends, I sincerely believe, based on my own personal experience, mental illness is not a big challenge as we all think. On the other hand, the system's deficits, it is the system's deficit that makes it a challenge. When the psychotherapist says, don't pass on your anxiety to your son, have they ever thought, why does my anxiety come? My anxiety comes because there is no ambulance to come and take. The ambulance is there, but the minute you tell them, here is an emergency, they say, oh, naam barakagalla. I can't come. We can't come. Mentally ill person, they are violent. We are scared. Fundamental deficits in the system. Secondly, we can't take the person who need of treatment to the consultations, whether it's private consultation or in government hospitals. All sorts of stories. Let's go and have lunch at Taj. Let's go and do this. Let's go and do that. Or we stick to covered medication. Because of the system, not because of mental illness. In fact, I see mental illness when you are very transparent, logical, reasonable, to some extent control your emotions. It's not difficult at all. It's possible. But all sorts of these surrounding factors at the system, at the macro level. Even I was reading the NIMHANS report, beautiful statement, I don't recall just now. The treatment gap in India has to look at the macro and the micro as it unfolds. Something like that it says in the recommendation. It is beautifully worded, and that's what I'm trying to present before you. I didn't realize that until yesterday when I read it. And thanks to him, with this presentation today, I'm able to remember that. As a result of this system, they say, what happens inside the family? We are labeled dysfunctional families. On a day-to-day basis, there is fights inside the family, social, emotional, legal, criminal, financial challenges, homicides, suicides, notwithstanding. All this happens, different levels. Or we hide everything. We isolate ourselves. I dropped out of all weddings in families. We are a huge network of extended joint family, one of the oldest families in Bangalore, my in-laws family. I stopped. Today, because I withdrew, today my son doesn't have any contacts with his cousins. I withdrew. I didn't know what to say. You read that article, that book, Dr. Murthy showed on the screen, you will understand that. So what happens? These challenges, the burden not from caring. I am not burdened from caring. Caring is a very divine thing to do. So burden is not from caring, but from systems deficits. There is no burden of care, but inadequacy of support, although the rights provided for it, especially the rights, section 18.5 of the Mental Health Care Act, please read. It says the government should support the PMIs, the person with mental illness, to live in their families and to extend support to the families. All that we are saying here is, please look at the legal framework. And therefore, burden of care comes with that, the treatment gap comes. Now you understand how things happen. So before I go to what is assisted home care, I hope you are all convinced now the existing pattern of services, that is all services which are community-based, need to change or need to be supplemented. That is not adequate. It needs to be supplemented with family-centric, home-based services. Before I go on to what is assisted home care, let me tell you what is not assisted home care so that it becomes easy to identify the features of assisted home care. Assisted home care for mental illness implies doorstep delivery of a range of psychiatric services on a routine basis. It is not emergency care. It helps to reduce or eliminate emergency by fulfilling the unmet needs of families. Assisted home care for mental illness is not required for all families. It does not require psychiatrists to make home visits. Please underline. That's the first question I'm asked wherever I had made the presentation in professional circles. Psychiatrists are like any other specialist, just like cardiologists, gynecologists. No need to visit. No need to make home visits. Even the project Dr. Murthy was referring to, Dr. Chauhan's project, late Dr. W.H.O, who started in 2014, which is continuing in Chandigarh even today, doing exceedingly well. It's a remarkable case study in home visit, Parivartan NGO, in collaboration with government hospitals, PPP model, public-private partnership model. Psychiatrist doesn't visit. It is the psychiatric social worker and the team, the nurse or whoever it is who visits. It is not necessarily free. This is very important for the middle class to be covered under the government service. It is not possible given the government resources. It is only government, definitely, and we support the government catering to the below poverty line. We are very happy about it. We are ready to give. We are ready to pay for other services. We don't want it free, but it should be affordable and accessible and reliable and dependable. It is not necessarily free, but it is affordable, for which diverse types of financial models under PPP and government grants, etc., can be explored. In fact, there is a publication report by the Ministry of Health and Family Welfare. I would be very happy if you all go through it. It explores a variety of public-private partnership models which an NGO can enter into or a government can enter into with other entities, NGO and the government, NGO and the family self-help groups and the government, so on, either 3-level or 2-level dyadic relationships which can happen under PPP model. It's a business model or a finance model or a charitable model, whatever it is. It's a beautiful report. And that report tells us about the various ways in which this can be explored. Even a residential institution like MPA, halfway home, can explore these things. It is not exclusively a government service. Private sector initiative and government licensing can also work. NGOs with exposure to and experience with mental illness can also set up assisted home care for mental illness with license from the government. That's why I gave the illustration. MPA can also go into it. What is assisted home care? It is simple. Assisted home care for mental illness is doorstep delivery of a range of mental health services that are related to treatment, medication, rehabilitation, therapy for PMI. PMI is person with mental illness, and the family, including information on legal and long-term care as well. Chandigarh is a very excellent model. Psychiatric social worker, Madam Shikha Tyagi, is doing it. And it's not just she's giving medicines or OPD visits or admitting patients. She's also in collaboration with Parivartan NGO. It's an excellent case study. The government hospital, late Dr. Chavan was the head of the Department of Psychiatry in Chandigarh Government Hospital. Now Dr. Preeti is the head of the department. She is the president of the NGO, and a family member is the vice president, Pamilamba. So it's a collaboration, it's a PPP. And it's not just giving medicines. Sometimes it's rehabilitation. They run their own rehabilitation center, Parivartan. Sometimes it's legal information, how to manage property, how to write a bill for the PMI, or is the PMI capable of exercising financial, whatever financial rights they have to do, financial management of their own finances, rather I put it in this way. So all this wide range of end-to-end service, the entire package. Mental illness is a lifestyle, my son says, and I agree with him. I mean, it's a lifestyle. It's beautifully said in few words by him. It's a lifestyle. Finance to marriage to divorce to loneliness to this and that, etc., etc., etc. Assisted home care and mental illness is within the framework of rights under section 18.1 to 18.c and section 5A, B, and C of the Mental Health Care Act 2017. In other words, it is a rights-based service. We are talking about a rights-based and not a welfare-based. It's no longer a welfare that is given. The person with mental illness has a right to this service, and we request the extension of the service beyond the community to take a leap into the family household. So this is how the flow, the flow of services, doorstep delivery. You see 3 verticals here, and each vertical is headed on top of it by a orange red box. The first one is vertical, we can call it as Medicare. The second one is rehab care, and the third one is recovery care. By recovery care, and it need not necessarily be a recovery in the sense of recovery from a cold cough or a viral fever or whatever it is. Recovery in mental illness is totally different, and Dr. Murthy is here. He can answer the questions on what is recovery if somebody has a question on it. But what I mean by recovery here is long-term plans. Long-term plans, there is nothing negative or positive about plans. Plans are plans in life. That's all. Life we have to make plans in life. For everybody has to make plans. So whether it's positive or negative is a secondary issue. Here, some special plans may be needed for a person with a disability. That's a recovery care, we can call it. So there are 3 verticals here. So the first one is the first box, first 2 boxes, purely medical in its orientation. The team visits the house for diagnosis. And presently what is happening in NIMHANS is they have given a mobile number, which any family in Bangalore urban calls, and then they visit home. They do the assessment, a consent form is filled up, treatment plan is given, and it's shared with the family, and other things happen like family therapy, follow-up visits, you come to the hospital, things like that. Then comes slowly the usual milestones in the treatment of mental illness, which is not purely medical, which is not purely social or purely legal. It's somewhere a lifestyle. It's a paradigm of lifestyles. So comes psychotherapy, then rehab potential, assessment of rehab potential. There are separate assessments for rehabilitation. Dr. Murali is present. He is an expert in this. The person wants to continue education. These days you find probably the MPA, Dr. Joseph and others would be able to say to provide whether my observation is right or wrong. They may validate my claim, my observation, that most of the homes today, on an average, the average age of the residents is not less than 35 to 40. And this generation, that's what I'm trying to tell you, is seeking. It's an achieving generation, seeking. They want to do something or the other. They want to study more, some course, some kind of an applied level course, not highly theoretical. There are people who follow even PhDs and others. We have a few PMIs in our group doing PhD with all the other challenges of medication. They want new job skills. You see the IGNOU website, Government of India Open School website. It's so creative. Every year they are adding new and new skills for training. And this open school is a marvelous kind of rehabilitation opportunity. Education, continuity of education is very important these days. Skills training is important. That is something which 2 decades back was not so well developed in psychiatry. Just making a person sit down and do tailoring or screen printing. Whether the person wants to do it or not was not thought about at all. But today, under the Rights of Persons with Disabilities Act, the person has to be consulted. So assistant rehab care is a second box for which home visit can help. Family is not just a medication, but rehab information. Of course, the team cannot find a job. That's not possible, placements. They may link the family with placement opportunities. That is exactly what we are saying. Whereas it is possible to get the treatment and the medical thing done, because basically this is attached to some sort of a psychiatric unit. So that is very important. The treatment unit should be there as a backup support. And then we have the legal information required, financial inputs, guardianship requirements, life care assistance, whatever it is. Along with that, the client's follow-up care, lifelong follow-up whenever required, also continues. This, in essence, is what we in Maitri put all our stories together. And I got all the numbers together, statistics together, and this is what we have at the end of it. And this is what we negotiate with the state governments. And some contacts here I've given. That will be in the chat box. We are apart, but we are still apart. Mental illness definitely is an integral part of society, but it needs a little more care. Thank you so much. Thanks. I hope with this, I hand over to Rohini. I hope.
Thank you.
Rohini.
Thank you very much, Nirmala. You have presented a very, very comprehensive, critical, and most importantly, a hopeful picture of what each one of us can do and what each one of us has to do to bring about the changes. Now the presentation is open for questions, contributions from the audience. I'm really glad that there are nearly 50 people participating in this session. I'm sure there'll be many contributions from the audience. I see in the chat no questions or anything so far. Rohini, if there is anything, please bring it up from your side.
They're asking her to share the second last slide once, if possible. There's somebody who's asked for the...
Yeah, the contact details, yeah.
The contact details, yes.
Yeah.
1 minute, please. I have to
It
go
went
back.
off very quickly.
I thought Rohini has put it in the chat box. That's why.
No, I was not able to. I mean, she hasn't responded yet, Aunty Saraswati. So,
Okay,
Take your
1
time.
minute.
Please take your time.
Yeah. No. Got it? No.
not yet, not yet.
Just a
Somebody
minute.
call Rajeshwari Iyer is presenting something? Yes.
Got it? Not it?
No,
No.
it's coming. But this is Infinity Loop. The presentation is not started.
Oh.
I can share the contact that you sent as just that presentation. I can share, but I can't
1
copy
second. I will just
Yeah.
try once more if that is possible.
Sure.
Oh, yes. Now I know why. The PPT I've minimized. That's the reason. I can do it now. 1 minute. Yes. Which one, Rohini?
Last but one, the contact
Last
details
part. Yeah.
Yes.
before the thank you.
Is this the one?
Correct.
Yeah,
This is the one.
Yes.
Yeah. Just leave it on
No,
that.
I've given the contact details. Apart from FACEMI, our group, I've also given for NIMHANS assisted home care in urban Bangalore, and also Chandigarh one, Parivartan contact, for those who are interested in contacting in Chandigarh and Tri-City. Parivartan contact also I've given.
Yeah.
There may be many more cases in India, but unfortunately I'm not aware of them. So I'll be glad in case some people share this assisting with for us to know. Yeah.
Contributions from the audience, participants, or reflections, questions to Rohini, to Nirmala. Mohan, you want to come in? Murli?
I just want to say,
Yeah.
and
Please
Nirmala
go
ji,
ahead.
I just want to know question after listening to Nirmala ji, and lots of questions to self, but it's always inspiring to listen to her.
Yeah.
And the need for legal literacy and advocacy is something I think she is very passionate about. And I'm also learning that from her, the importance of that. Thank you, Nirmala ji.
Thank you, Mridula. Thank
Mridula
you.
is from the Richmond Fellowship, Delhi.
Yes, thank you.
And very nice to see Dr. Murthy, because it's been a pleasure having you in our webinars. So this has been an excellent presentation and thought-provoking.
Yeah, probably questions may not be forthcoming because I think all of us are jolted a little jolt.
No, thank you. I'm sure there'll be, just take a little time to, yes. Murli, go ahead.
Yeah, I think this was a very, very, very good presentation and very, very good introduction to the topic by Dr. Srinivasan, because I think this is the issue of the hour. Now, one of the problem which comes is that at the international level and the national level, there is a lot of issue talking about the rights of the persons with disability, and we are going far ahead without involving families in the legal context. And unfortunately, in India, out-of-pocket expenditure is a very huge expenditure for mental health. It is not completely covered by the insurance schemes, even though some of the schemes have come forward. All the complete service of mental health has to be covered as per the act by the insurance. But if the family is completely taking care from 24 hours, who will give the support? That is where the presentation's relevance come in. Similarly, it has to be incorporated in our act. We cannot go with the Western Act because 23% of the population talking about for the 87% of the population cannot be accepted. So this is something wherever we have developed this program has to be highlighted, and this has to be brought in as a unique services in India with complete involvement of the family. And from that angle, I really appreciate Nirmala for her very good work. And we all are there. WAPR as well as Indian Psychiatry Society, Karnataka chapter will definitely be fully with supporting this.
Thank you very much, Dr. Murthy. Thank you.
To come in with your cross-cultural experiences and
We can't.
Mohan, we can't hear you.
Yeah. Okay. Thank you very much, Dr. Nirmala Srinivasan, for talking to the MPA's, Suvarna Jubilee lectures. You have been pioneering this number of things that you have talked about, and some of the things that you have been asking for. Lots of things that you have worked on in the past have resulted in outcomes. For example, you said that now their family is coming together. It is not just a small group in one or two places, but there are zonal groups everywhere. So since I have known your work for a long time, I know that with persistent effort, you have been able to bring forth a lot of things that you have been fighting for. And I'm personally sure that the assisted home care that you have been talking about will also slowly become a reality, little by little. It's already beginning in few places here and there. You talked a number of times about Parivartan, the NIMHANS domestic care or home care program also was referred to. Anyway, what I wanted to tell you is that most of the kind of principles of what you talked about, you very clearly mentioned what is not assisted home care and what is in fact assisted home care is referred to in many Western countries as assertive community treatment care. The short form is ACT, assertive community treatment care. In fact, a part of my clinical time, ever since I came to work with the University of Western Australia here in Australia, I do about 50% of the time clinical work. And from 2010 onwards, for over 10 years, I've been consultant for a community treatment team. The community treatment is exactly what you showed in that one diagram. It is what you have referred to as assisted home care. There is a team. The consultant is the consultant psychiatrist is the head of the team, but we have numerous people whom we refer to as care coordinators. Care coordinators, a team of multidisciplinary. It's a multidisciplinary team consisting of social workers, community psychiatry trained nurses, occupational therapists, and more recently in Australia, we have created a new group who are called as community mental health workers. With little, so they don't have to be very highly trained social workers, but they are trained for this kind of work, for providing the assisted home care. So this is, of course, not for all the people living in the community, but for a group of people with special needs. Now, you have thrown a challenge to all mental health professionals and also non-governmental organization such as Medical Partial Association to start this kind of a program. I think it is eminently doable. Parivartan has taken a step and it's also developed a particular kind of model. I do not know why MPA cannot do it. MPA, this series of lectures as part of which you have come in today is the Medical Partial Association's Golden Jubilee series of lectures. And I think MPA and the committee, the president is here, and many other people are here, should take it seriously, whether this can be done, at least for a certain section of Bangalore. The number of points which I noted down, which are of great relevance from her talk, is that there is a growing urban middle class. It is true that India is largely becoming urbanized. In another 20 years, nearly 50% of not only Maharashtra, but most of the country would be urbanized because cities are growing larger, more and more. This is a phenomenon which is occurring all over the world. In a country like Argentina, which was perhaps very similar to our country many years ago, now 95% people are urban. So the growing middle class, and you also said that I think the important point that I would like to highlight from your talk is that this is not a welfare-based service, but this is a rights-based service. In other words, this is not like the service which many non-governmental organizations have come up for the homeless, mentally ill, like the Banyan and all that. But this is a right-based service for people with mental illness, with varying problems and varying abilities, who can live in the home, but who need this crucial additional support. And then she said it should be affordable, this is accessible, reliable, etc. So, in fact, just about 2 months back, I came to attend the midterm CME. It used to be called the Continuing Medical Education Program of the Indian Psychiatric Society. Now they call it the Midterm Conference of the Indian Psychiatric Society. It was in Srinagar, and I was invited specifically to talk about assertive community treatment, how it can be adopted in India. Much of what I said in that presentation is exactly what you are saying. I didn't call it assisted home care. I think you should patent it as assisted home care in India. And I think now not only MPA but most other, this should be talked about widely, and people should be given the the technique of how to start this. Taking the example of Parivartan, things are very different in each state and each city in our country. I would personally, of course, urge the committee of the Medical Pastoral Association to explore. I mean, Medical Pastoral Association has been largely providing residential care and then daycare. But I think one of your slides showed what about the more than 60% who don't fit into that. There's no reason why MPA should not start something like an assisted home care. Thank you very much, and back to you, Chairperson Dr. Murthy.
Thank you very much, Mohan.
Thank
There are
you.
2 requests for questions, besides lots of appreciation. Asmika, Treasure, and Dyson. Can you unmute? And Asmika, first you can come in.
Sir, there are questions from others as well on the chat.
Okay. I just saw these 2, so we'll come back to that.
Sure.
Asmika,
Good evening, sir. I am from Asmika.
please go
Am I
ahead.
audible? Am I
Yeah,
audible?
we can hear you. Please go ahead.
Yeah. Good evening, Dr. Nirmala, madam.
Good evening. Good evening.
It was very nice hearing so many things about AHC. And in fact, in the practical field, what is happening is, though we define AHC is not an emergency, due to lack of adequate staff, even in Bangalore AHC2, that they define it in a different way, that is there a need for AHC, or can the PMI be moved to OP? If the PMI can be moved to the OP and to the clinic, they insist for it, and they call for what is the reason for us to come to AHC. This is the practical situation, and I don't know if it is improved now, because I was hearing the presentation of the AHC model earlier in the video. They said there is inadequate staff and people are not willing to work in AHC model. May I know an update on this, or if you know it? And I think unless the government accepts the definition as defined by you, probably the HC will remain on paper.
Thank you, Asmika. Can we take Dyson's question and then you can respond both of them, Nirmala, if you don't mind?
Yes, Dr.
Dyson,
Murthy.
please go ahead.
Yeah, hi. So my name is Dyson. I'm from the United Kingdom. I live in London. I'm actually a founder of an organization called W.H.O. We're basically trying to work with care professionals in India. I mean, when we talk about care, we look at care very from a medical point of view, especially in India. But in this particular group has kind of given me a kind of limelight to the fact that yes, care is actually looking at social aspects as well. I think I agree with Dr. Mohan as well. You know, there's a lot of work that needs to kind of be put in from the community side point of view, because I mean, in UK as well, we have community healthcare models. What I'm trying to also kind of understand is how, Dr. Nirmala, your perspective in terms of the concept of person-centric care, looking at rights-based approach, because when you have these laws and acts and guidance, it's already there. The system should automatically implement these things because it's mandated by law. But sometimes the system people really don't understand. Like, for example, looking at emergency medical care for somebody who has mental health emergencies, ambulance services might not necessarily come there because they don't understand that that is a life-threatening condition even for them or for the families. So I just want to kind of get your perspective on that gap in how the system implementation is. Because when we plan to do trainings for care professionals in the long term, partnering with organizations, because we feel that there's a lot of social point of view that can be integrated into the care model in India, which is largely hospital based at the moment, which is again something that needs to kind of come to. And we talk about families, yes, but families also need additional support. Like India has one of the largest loved one based care support in the world. So how do we kind of work with these environments as well? Thank you.
Nirmala, can you take both of them?
Yes. The first question, of course, I couldn't understand the question much. Asmika, what exactly is the question? Is it the health workers don't want to work?
No, he's referring to Nirmala. If I can just clarify, he
Yes.
was referring to the last presentation of AHC, where they said only 10 people had come for sought help, and there are problems in that.
Yes.
Probably he's
Oh.
saying that what are the
Yes.
teething troubles that we have at this point of time,
Yes.
and how
Yes,
we
I
can
got
get
it.
over that.
Yes. So it's just any change takes time. In fact, people will, as you know, it's no doubt inevitable to happen in a course of time, but it takes time. And also most of these AHC team members, the other day we were sharing, NIMHANS had invited the FACEMI for a dialogue, for a feedback on what is happening, how to improve it. Most of these are trained to, even the words they use is trained for clinical communication. Once you step into a family and start talking, the entire communication pattern has to change. And it will take time. It's not going to, it's just June. It started in June 23, and we are in December, end of the year. Its actual plan rolled out, I think, probably in August, the first visit. It's going to take time, and I'm sure he'll pick up. It will take time, like in any other intervention which is new and novel, whether it's a service provider or the service receiver. Even many families are not even aware of it, or not keen. What will they do when they come home? Are they going to solve my problem? This is the question families ask. They're not going to solve. They'll visit and go back. Now, there is time for all this. This is the only way I can answer this question. Training is very important for these people. It is not enough to give just medical training. Somebody said social, medical, also communicating with families needs special communication skills. And also updating themselves. Most of these health workers are not aware of the rights. Mr. Dyson was saying, can I call you Mr. Dyson? I don't know if you're Dr. Dyson or Mr. Dyson. So he was saying
I'm Dr. Dyson. Dr. Dyson is fine.
And Dr. Dyson was saying about health workers' rights. How do you integrate health workers' legal literacy for families? The first ever program was done by my NGO at that time, ACME, in 2006. Until then, many families did not know. I'm sure NIMHANS has done some programs and all that, and other institutions also. But as an NGO, family-based NGO, so legal literacy is very important. So only way I can respond to Asmika's question is, it's a matter of time. I'm sure it is going to be all right, but these are teething troubles, as Dr. Murthy said, and any change is a bit of a threat to everybody. Not just the person, a change agent, but also the change agency where it is targeted. So coming to
questions, Nirmala. One is Debanjan and other one is Anjaneyulu.
Can I answer Dr. Dyson's question? Can I answer Dr. Dyson's question?
Yeah, please go ahead.
Yes, integrating all this in healthcare. Yes, a broad-based, we have to revamp the training package because the paradigm is shifting from community to family. Even here in the dialogue which is happening now, they are equating unintentionally, inadvertently equating assisted home care with community interventions. This is a totally different paradigm, family-centric. It is not of course, WHO is expert, has provided a lot of quality rights for mental illness in community care settings. Probably WHO is yet to develop any paradigm, yet to develop any guidelines for those working in families, not families within the community, but families within family per se. It is a totally different thing. It's going to take time. We are willing to work with any other NGO or expert group, whatever little we have not done as a group, FACEMI as a group. We have not done any professional work or this thing, except me. I've got into some researches. I'll be happy with Dr. to get more information from Dr. Mohan Isaac, the assertive community interventions, Dr. Mohan Isaac. I want some literature on that. Also, Dr. Murthy said about he referred to two literature in 1980 by Dr. Kapoor, I think. That is it. And I personally want to convey my thanks to Dr. Mohan Isaac for encouraging MPA, to take up this. This is one of the things which is they, and in fact, assisted home care is more cost effective than running centralized services, whether it is institutions or communities. And Dr. Murthy already said patient outcomes, quality of care helps better patient outcomes. So there's nothing like it.
Thank you.
Grateful.
Can I ask Debanjan to come in? Because we are running a little late, 5:30 already. Yes. Can we take another 15 minutes, Rohini?
Yes, sir. Absolutely. Absolutely.
Okay. Please go. Debanjan, please come in.
Hello, ma'am. I'm Devanjana.
Yeah, hi, Devanjana. Devanjana is the founder of Shakti FACEMI Calcutta.
Okay, very good. Welcome, Debanjan. Please go ahead. Please share experience and
yes, ma'am. Though I heard about assisted home care many times from you, but still I have a question because I feel most of the families face problems when the person do not have insight. So taking them to doctor regularly becomes a challenge. So in that case, can someone come and convince the person and directly take him to doctor with the families? Is it a plan?
Yeah, thank you very much. Yeah, go ahead, Nirmala.
Yeah. So Devanjana, very good question. I don't think anybody has found an answer as yet. You can drag a horse to the pond, but making the horse drink water is a big question. However, I'm told in the Bangalore urban NIMHANS project, 3 persons with mental illness, 3 cases, potential need of treatment, 2 cases, dropouts from treatment, have been convinced by their team. So this is
very good.
Yes, it takes time, but may not be 100% success. It takes time. Community projects are also not 100%. So also hospital admission not 100%. At least in this case, we can reach to the largest numbers who are left untreated.
Yeah,
I just want to come in at that point, Debanjan. I think as a psychiatrist of the more active in the early part of the 50 years. This seems to be an emerging problem from the mission group. Number of parents are saying it. I think we need to address it in a little more specific manner and find ways of convincing, because it was not a major problem. It was not that it was not there, but it was not such a major problem as now it seems to be coming. The same thing was mentioned by Iyer, who left Rajeshwari. She left the group just now. She also raised the question. I think it's worth addressing it much more intensively. Anjanelu, you had a question for about FACEMI.
Dr. Murthy, one minute, if I can share your concern about this question. It's not just a medical problem. This problem of insights can also be from the environment. The family ecosystem can also promote and intensify the lack of insights. So we should address from non-medical point of view as well.
Okay. Thank you very much. That's why I said I think we need to really look at it. What are the characteristics? What phase of illness? What else is happening? So that we can find solutions.
Yes.
Anjanelu, would you like to come in?
Yeah. Good evening and good evening, madam. Namaste, Dr. Nirmala Chi, madam. My question is actually, my son is a PMI. He's 18 years old. I live in Hyderabad, and based on I joined this session 10 minutes late, and by following the later on discussion, I understand that this FACEMI is based on Bangalore. So my thing is, I am looking for some help in Hyderabad. Is there any chance that any similar organization or anything is there in Hyderabad? Basically, the sort of help I am looking is due to the depression, whenever my son gets depression, he beats his mother. So because of that reason, for last 6 to 7 months, I am doing work from home only, which is becoming a problem. Organized, my company is asking like you need to come to office, but due to the risk, I'm not able to go now. So for any such situations, is there anything? Are you aware of any help that I can get in Hyderabad?
Yeah, Dr. Murthy, can I?
Yeah, please go ahead. Please
Yes.
go ahead.
So Hyderabad, there is we don't have FACEMI in Hyderabad, but we can connect you with groups there. Of course, their perspectives are different to the way we look at it. So it's up to you what exactly we can give you the contact number. They
Sure.
are members of our group as well. Hyderabad people, I'll give you the contact of, I don't know, can you connect with, can you take down my number and call me? This is my WhatsApp number.
Okay, sure, madam.
Yeah,
Sure.
I'll send you some numbers there in Hyderabad. 98860.
1 minute, madam.
Yes.
Take your time.
98860
98860
31
31
659.
659. Okay, madam. Thank you so
Mr.
much.
Angeleyu, I have a request. I take the liberty of advising you if you don't mind.
Please, no, madam.
Kindly just say your son is symptomatic. Don't share much about him without his permission, whether he's beating his mother or beating his pets. No, he's doing it
Sure.
beyond his control. And this is what FACEMI believes, that we believe. This is the right space. He has a right to his privacy. You start with that and you see, you find a lot of solutions from within the family.
Sure, madam. Sure,
We'll
sure.
talk later about it.
Sure, madam. Sure. Thank you
you
so much for that suggestion.
Thank you very much. I don't see anything else which is from the chat box. Anyone would like to come in before we move on to the closure of the session?
So there are 3 hands that have been raised, Dr. Murthy.
Yes.
3 people have raised their hands. So can you please
Can you
unmute
just ask them to please? I can't see them.
Yes, sir. Mr. Chandu Kale,
Mr. Kale,
and someone from Asmika. Please go ahead and
please
ask
go
your
ahead.
questions.
Chandu, please go ahead.
Please unmute yourself, sir. Mr. Chandu Kale.
Chanduji, please unmute.
Okay, I think
now we can hear you.
Yeah, okay.
Yes.
Now I have a question for Mohan, Isaac, and Dyson. The question is, they are organizing a community mental health workers training program. So, what are the details that probably you can send on FaceMe so that we also organize similar courses in India if possible? Because to get the assistance
I'll take it from them. Yes. Rohini,
Yes,
kindly
that's it.
facilitate that, please.
Sure,
Yeah.
absolutely,
Yes.
absolutely. No
Yeah,
worries.
that's the only question. That's it. Okay, thank you.
Thank you, thank you. Life coach Veena, please go ahead.
Yeah, hello everyone. Very powerful discussions. I mean, I have interacted with, I've been off and on a caretaker. So I realized something which really works, and I just wanted to share is, you kind of listen to them and you accept, and be very tolerant and very affectionate. And I see that they really listen to you. It's only when we lose patience, things become ugly. And also, I'm a certified life coach, so it comes from there also. I think we can decide the kind of energy we want to give to them. Do we want to pass on negative, ugly intolerance, or we want to pass on affection, love, and affection? I think the biggest formula which works for me is that just treating the person like just respect him as a human, irrespective of some issue. Just respecting him, giving him the due respect to his beingness does a lot of wonders. I wanted to put that comment across to everybody, and that's it. That's it from my side.
Thank you very much. Thank you.
Someone from Asmika has raised their hand again. Asmika Treasurer.
Yeah.
Yeah, I have just one doubt regarding the AHC. In the assisted home care, there's some project is started in Bangalore. I am very happy about it. But the project, of course, it takes time, as Dr. Nirmala said. But as the mental ill are growing in urban, why can't the government think of making it mandatory to join AHC? Because what I observe is reluctance of the qualified people to join such a program. Like it made mandatory for rural service for all the doctors. In the same lines, the whoever completes the qualified psychiatrists or qualified social workers should be made mandatory for them to work at least for 3 years in AHC services. I think we may have to insist.
Yes.
Anyone else,
AHC,
Rohini?
because everyone wants a comfortable zone to work.
Thank you very much for the suggestion. I wish some government officials were here to hear that out. Thank you very much.
Dr. Joseph George. Dr. Joseph has raised his hand. Please go ahead, sir.
Okay. Dr. Nirmala, thank you very much for your very enlightening presentation on assisted home for the mentally ill. And you presented to us the gap that exists between those who obtain care in some form, around 35, 40, but the remaining majority remain without reaching, they are all under the family care. So this is something I open up for us. As Dr. Mohan suggested, MPA probably also may need to look at a different model in the coming decades to look at how to include more the people who are struggling with mental illness into our service. Because you said look at the people who get service, and I was looking at the age group as well as the socioeconomic background of the people at MPA today. They are more from the upper middle class background, and not many from the disadvantaged group. So this is something a big challenge for all of us, including MPA, to look at. Now, when you said people get 70 to 80% under home care, there is one observation I want to make, and I want to know how would you deal with that. So those under home care, whether urban or rural, my observation is majority of them do not have any professional help, including medication.
Yes.
And only a minority get professional help, or minority go to a doctor and get help. So there is a big gap even in that home care group. How would you see this can be addressed in the future years?
Here, Dr. Joseph, I think by home care, you mean family care?
Yes, family
yes,
care.
That is exactly what we are saying. The accessibility is not there. That is why when they are not able to access, you do the outreach and give the medicine. For example, I think presently in Karnataka, taluk level district mental health programs in 10 talukas started assisted home care. And Dr. Rajni, who is in charge, nodal agents for Karnataka DMHP, she was sharing with me that at least 40% cases, it could have mental illness could have been prevented in those children and adolescents if only access to medication is available. This is the problem. We have to have an infrastructure. There should be some sort of a outfit there to do it. We can't just have a concept and design like desk work, which I have done. You should set up. That is to be done. Government of Karnataka, this is only possible, Dr. Joseph, if there is a public-private partnership collaboration. Because funding by the government alone is not enough. And the middle class is willing to spend, but not beyond the point. For example, if they go to a private psychiatrist, the psychiatrist tells them, okay, now you can go to a counselor. Which counselor? The psychiatrist is not able to tell them. Or you can take them to a rehab center. Not only inadequacy of medicines, but inadequacy of other interventions are also there. For all these things, it is very important for a collaborative effort. Chandigarh example, for instance, it's an amazing, incredible collaboration with a psychiatry department and an NGO families of a family. The NGOs run pay the driver's salary for the bus to the team to visit home. They have the van and they collect very minimal membership, annual membership and life membership, and they run other facilities also. So besides the various public-private partnership models, MPA cannot initiate this on your own, with your own capacity, financial capacity or human resource capacity. It is not possible. We have to follow. I'm just giving it as an illustration. And we can discuss this later when I'll come on this.
Nand, can you ask the question? Nand?
Hello. Hello. Thank you for a very, very interesting presentation, Dr. Nirmala. I really enjoyed it, and it was very informative. So what I would like to know, actually, you know that my son has schizophrenia. So when you seek assisted home care for any child who is not well, so are we taking into account the permission of the patient concerned? Are we asking him or her that, are you okay? Shall we ask for some assisted home care before going ahead? Or is it a decision by the parents or whoever the guardian is? I don't know whether it would be the parent, that just go ahead. Let's just call somebody and let's hope that that person can convince my ward to go for treatment. In the case, my son, of course, I wanted him involved at every step, but I'm just interested in knowing what is the way forward.
Yeah, Dr. Murthy, I'm going ahead with the response to Nandini.
Sure.
Yeah.
Please.
So this is a very brilliant question and a big challenge currently faced by the NIMHANS team. That is informed consent, as they call it. I think Mohan Isaac can also, Dr. Mohan Isaac can throw light on it, much more light on it, because he has experience in the field. What I believe is, one thing is informed consent is very important and very helpful to go along. But even if it is not there, the Act itself provides for any help done, provides for the protection or the legal immunity of the staff, any help delivered, anything done to protect, to treat a person who is in need of treatment, you will not be taken as a violation of the rights of the person or the privacy of the person. So that from the legal point of view. But looking at it from the day-to-day interaction with families and others, there is no such guarantee that this can happen. We only believe. That is where the training is very important. Training of the person who comes into the house. I was in fact telling Dr. Krishna Prasad and Dr. Aarti in NIMHANS, let them not even wear white coats. They are now not going in any ambulance. They can get an ambulance. They're going in Ola or Uber or auto, whatever they get. Just step in, have a friendly conversation. Like, you remember those days, I don't know whether it happens even today, the visit of the parish priest.
Yeah.
It was the beginnings of therapy, what they call us today. Very friendly. And have a cup of tea. At that is very important. I don't know whether Dr. Mohan Isaac would like to respond with the Australian ace, Dr. Isaac.
Thank you very much. I think this is a very important, what Nandini Sachdev raised is a very important problem. And in a way, this came up in an earlier discussion when one of the participants mentioned about his son. Of course, in his own crude way, he mentioned, and Nirmala also pointed out. But what that person was saying was that his son is unwell. Sometimes when he's, in a state where he is not in control, he beats his mother, etc., etc. And Nirmala pointed out that, no, you should not discuss without his consent, etc. This is the right place. What Nandini Sachdev says is this is all fine. In the real ideal world, you get informed consent, when you give treatment, there is the assisted home care, everything works well. But in the real world, not all our people have that insight. The lack of insight is a problem. Initially, they don't think that is an illness. They don't think that there is medications required. Maybe they have a poor experience of doctors in NIMHANS or elsewhere forcibly giving medications. For example, maybe a long-acting injection which produced an extrapiramidal symptom or an oculogyric crisis, the eyeball rolling up. So they say, no, I don't have any problem. Now, how do you deal with this? Of course, we know that they are suffering psychosis. They have no insight. We are supposed to follow LPD guidelines, informed consent, etc. How do we deal with it? I will respond based on my own personal experience. I said earlier that I am the consultant here for an assertive community treatment team. Let me just add on, this assertive community treatment is just a Western, there's a historical evolution of the assertive community treatment team. In fact, the mid-SIPS, the IPS presentation, I will send it to Nirmala Srinivasan. Because he asked me, I will send the PowerPoint. The way it is adopted, what Nirmala calls assisted home care, and she referred to Rajini and the NIMHANS Taluk mental health program. In fact, the term they call is care at doorstep. In fact, they have even made a abbreviation, CAD, care at doorstep. Essentially, some of the aspects of that Nirmala mentioned, anyway, coming back to the problem, India has a new mental health act which is being implemented to some extent. One of the things that was discussed during its development, but it has not been included, is the provision of what is called as a community treatment order, which is there in many mental health acts and legislation of many countries, including Australia and New Zealand. This is a kind of an involuntary treatment order. It is not like a treatment order to take the person to a hospital and lock them up or keep them under, or something like that. This is a treatment order to be provided in the community. So, in fact, the team I look after, we have 6 care coordinators of the kind I mentioned earlier. Each one has a caseload of 12 people, because this is so by past research and by international convention, we know that a care provider can at a point in time have up to 12 clients in the community. So I look after, as a consultant, about 72 people. I'm giving the numbers just to give you an idea of how many people at any point in time out of 72 would require a community treatment order. At any point in time, we would have 3, maybe 4 people on what is called as a community treatment. What is a community treatment? We see, for that, the psychiatrist may have to visit home along with the care coordinator, because only medical person, according to the Australian law, is empowered to put a person on a treatment order. So if it is like somebody's son who is saying, oh, he's unwell, this, that, family thinks he needs to be on treatment, the assisted home care team comes there, the psychiatrist says, look here, so-and-so, this is it. These are the symptoms. You don't agree. We have a normal conversation. We would like to start you on treatment. This is the treatment. You say, no, I don't want any treatment. Then the psychiatrist very politely and very gently say, under these circumstances, no, at this point in time, you need treatment. And I'm using the prerogative of the current mental health. Here, we call it the Mental Health Act of 2014. Mental health acts keep getting revised in every country because, the rights-based provisions, etc., people become more and more aware. So I tell them, he said, no, this is not all right, etc. But I put him on this. I say that according to this, now you will need to take this tablet. You can't put tablets down the throat of a person if he is not willing. So very often, initially, it's a long-acting antipsychotic injection. And we have very good ones now. So we give them. Now, what is his right? He can, within 3 months, by the law here, every community treatment order which is issued by anybody has to be reviewed by an independent tribunal. Something similar to that is in the Mental Health Act in India. The independent tribunal is a 3-person. One is a legal person, one is a community representative, somebody like you or Nirmala, Srinivasan, not a psychiatrist, not a mental health person. And the third is a senior psychiatrist who is not working in the service very often. They independently review whether it was right on the part of the doctor to go and put the person. And usually the life in WA, the life of a community treatment order is 3 months. After that, very often by virtue of the injection, the person says, oh yeah, it's helping me, I'm happy to continue. So that's how you deal with it. In India, this is a problem. Many young people have talked about and written about, do we need a community treatment order in India? I personally feel, like Nirmala said, people like Manjula and her team and the Taluka mental health, this is a problem. They are, of course, now evading the law. If there is a smart young man who is forcibly given treatment, he can take them to the court and then there could be problem, So treatment order, otherwise called as CTOs, are the legal provision for managing people in the community, following every other thing which Nirmala said of assisted home care. Back to you, Dr. Murthy.
Thank you very much. I'm sure we can go on for another half an hour or 1 hour, but I think we must come to an end. I want to thank every one of you for your rich contribution, starting from Nirmala ji. I'll just make a few observations. One is that there is an enormous amount of experience available in palliative care of, there is both Karanashraya as well as Baptist Hospital. I spent 1 full day with each one of them. Similarly, I've seen the Trivandrum palliative care. We can learn a lot of lessons from all of them. In addition to that, I also want to say something. India can show this to be a very workable one, like it happened 70 years back for tuberculosis. You remember when the tuberculosis was institution based, it was the Madras group. We said no, we will do the community, and even Oxford said no, it cannot be done. It has to be institution, and now today it's accepted. So we can be in that area. I can't close this session without recalling another iconic figure who passed away in the last 15 days. I'm talking about Rosalind Carter, who was a pioneer in talking about family care. She wrote a book in 1998 called Helping Someone with Mental Illness, a common guide to family, friends, and caregivers. I just want to recognize and recall her when we are talking about the Indian situation. The last thing I want to say, a little more ambitiously or prophetically, we can show an Indian way of doing things. I am saying this because I just finished reading Raghuram Rajan's book, Breaking the Mold, the reimagining India's economic future. Let me just quote one sentence. He says, India is at the crossroads. We must embark on the Indian way, which builds on our strengths rather than our weaknesses. It should be based on building the human capital of every citizen rather than augmenting the financial, physical capital of few of the people. In a way, we grow will be a beacon to other developing countries. The assisted home care, care in the community, the family strengthening, if we can take it to a level of higher level of action, higher level of documentation, I think it will be a very big contribution from India. With those words, and wishing all of you a happy Christmas, happy New Year, I hand it back to the organizers. It has been a privilege to be a moderator, and thank you very much, MPA, everyone associated with it. Thank you.
Thank you so much. May I call upon Dipanjana to please render the vote of thanks. Dipanjana, could you unmute yourself, please?
Thank you, Rohini. A warm good evening to everyone. On behalf of the Managing Committee, staff, and residents of MPA, I'm elated to extend my heartfelt thanks to Dr. Nirmala Srinivasan, ASHOKA Fellow and founder of the Families Alliance on Mental Illness, and Dr. Srinivasa, Murthy, Professor of Psychiatry at AIIMS, Bangalore, for readily accepting our invitation and gracing the occasion despite your busy schedule. Thank you, ma'am, and thank you, sir. Your presence surely goes a long way to boost our morale, and we do promise to imbibe your guidance in our daily lives. I'd like to thank all the attendees, members of FACEMI India, and life members for inspiring us with your presence. I would fail in my duties if I do not thank the residents and the staff of MPA, who are the very reason for their existence as an organization. I'd also like to take this opportunity to thank our President, Dr. Joseph George, our Vice President, Dr. Rajit Bhire, our Secretary, Mr. Alphonse Kurian, and all other committee members for being our strength. Special thanks to Mr. Rajiv, Chairperson of the Academic Public Service and Publication Committee, for providing us with the Google meeting to make this program a success. Also, thank you, Rohini, and our Vice President, Dr. Rajit Bhire, for connecting to different dignitaries every month and coordinating to make the Suvarna Jayanti lecture series a huge success. I also extend my heartfelt thanks to the Chairperson of the Suvarna Jayanti Program Committee, Dr. Mohan Isaac, for his continuous support and guidance. Last but not the least, I express my deepest gratitude to Almighty God for showering His choicest blessings on all of us. Thank you.
Thanks a lot.
Thank you so much, Deepanjana. I have shared the YouTube channel of MPA on the chat. We will be sharing a recording of today's video over the next week or 10 days max. I must apologize. I started recording only when the presentation started because I got carried away in the discussion. I'm so sorry, but we do have the entire presentation as well. So.
Yes, a slightly belated happy birthday to Rohini.
You, sir.
Oh, many
happy birthday. Happy birthday.
Happy birthday. Happy birthday.
We should have got you a cake.
Yes.
Thank you so much. Thank you.
Thank you.
And Happy New Year to all of you.
Yes, Happy New Year.
We will the years ahead.
We will see you next year with our next lecture.
Thank you very
so
much.
much. Bye-bye.
Thank you. Thank you.
Rohini, I think you may wish to just add that we have on the 10th of February 2024, the second Dr. Joy Ceremony oration to be delivered by Dr. Vikram Patel, who is the Professor of Global Health, not just mental health, the Professor of Global Health at the Harvard Medical School and Harvard University. It is on 10th February, Saturday at 4 o'clock. It is called the second Dr. Joy Ceremony. The late Dr. Joy Ceremony, as all of you know, is our founder secretary of Medical Pastoral Association. Of course, you will get the circular and various other things from Rohini in due course.
Thank you so much, sir. All right. Bye-bye, everybody.
Bye. Bye.